started? Now, we left off last time talking about resistance. We went through these different factors here, referring to how we can alter resistance based on Poiseuille's law, altering the length of the airway, viscosity of the air we're breathing, or the radius of the airway itself. Anything that alters resistance. We talked about the multiple ways of doing that. We left off talking about bronchoconstriction and bronchodilation. So remember that, the parasympathetic system deals with bronchoconstriction. The sympathetic system deals with bronchodilation, as in norepinephrine or epinephrine. And carbon dioxide we're going to talk about further as how that comes into regulation relative to bronchodilation. So we also talked a little bit about work of breathing. And this kind of displays two different major factors that come into play when we're referring to work of breathing. Here we have the elastic work, which we talked about the elastic work and such that the compliance of the lung determines how much inspiratory effort we need to put in to get a particular tidal volume into the lung. And we also haven't talked much about, but we will a little more, non-elastic work, in other words, airflow resistance. We talked about various diseases, as in chronic obstructive pulmonary diseases that affect airflow through our upper conductive airway, whether it's mucus accumulation or some bronchoconstriction. So these two forms of work, and you can see the relationship of elastic work and non-elastic work relative to ventilation. So this here is frequency. Now, if you notice on this curve, now this top dotted line is the summation of these two contributors to the work. You can see here that a normal ventilatory rate, total work, is an optimum. In other words, we put forth least amount of energy at that particular ventilatory rate. Okay, so it's very important to understand that our body physiologically optimizes ventilation. And so you can see over here, required to maintain a constant minute ventilation. Okay, that's the mechanical work. So as we move left or right, and we've already talked about this a little bit, what happens if we increase our rate of frequency of ventilation? Typically, if we do that, we increase our tidal volume. So this is an example. So we go to 1,000 ml for a tidal volume times 6 breaths per minute. If we're on this extreme, you can see that the non-elastic work, airway resistance, is least. Now the reason that is because if we go to large tidal volumes, in other words, we're doing large inspiratory efforts. We have a very large negative pleural pressure. That negative pleural pressure pulling the lungs open also pulls the airways themselves open. So we have least airway resistance at higher volumes, at higher lung volumes. So that's why you see this so low here, and as we go up toward increasing frequency, decreasing tidal volumes, as we decrease our tidal volumes, now we increase the probability that these airways can collapse. Now also, if we look at the elastic work, as we discussed, that also goes along with lung volumes. We talked about the elastic work. So if we have a very high lung volume, in this case, we have a very high elastic work. We talked about the compliance of the lung as we reach very large lung volumes. In other words, it doesn't stretch very well. Okay, so the elastic work in expanding the lungs is very high. So hence, to stretch it once it's already maximally stretched is difficult. We use that example if you take a rubber band, you stretch it out a long distance, now super stretch it. Now it takes more force to stretch it that little bit extra. And that's what this represents here relative to elastic work. So now you can see the relationship between elastic work and non-elastic work, or airflow resistance. And make sure you understand that physiologically, our body does take this to an optimum to minimize the amount of work that we expend or energy we expend in breathing. This here, once again, this is the same chart. It just kind of simplifies the relationship here, but you can see flow resistive work is the opposite and goes the opposite direction of elastic work. So that gives us the same example. Because what we want to look at here now is minute ventilation. Minute ventilation is equal to the tidal volume times the frequency of breathing, as we discussed. And as you can see here, once again, minute ventilation can be the same even though we alter our tidal volumes or our frequencies. And the relationship of these to emphysema or pulmonary fibrosis. Typically, if you have emphysema, you have a tendency to breathe at higher tidal volumes. The reason for that is because, remember, we said that we lose our elastic recoil of the lung. So in order to limit the amount of work that we do, we breathe at higher volumes. Because now, because the lung is so compliant, if we breathe at higher volumes, now you can remember it takes more to stretch the lung out, but at least now we get a little recoil. Because we're working at such high volumes, we force the lung to give us some recoil and therefore ease the amount of work we do in breathing. Same with pulmonary fibrosis. Once again, we talk about small tidal volumes because now the lung will not expand very easily. It's very low compliance. So we breathe at small volumes and we breathe at higher rates. Once again, trying to minimize the amount of work that we do. So in essence, in these diseases, we do these various frequencies and tidal volumes to minimize work. Okay, so it's very important to remember that. So as we talk about various factors that influence the rate of airflow through the airways, we talked about resistance and the various, Poiseuille's law, the various factors involved in altering resistance, but there's some other factors as well that have effects on airflow through the airways. One of those is laminar versus turbulent airflow, or Reynolds number. We're going to talk about that just a little more detail, but Reynolds number is an indicator of turbulence, whether we're talking about airflow or fluid flow. But in this case, we're going to be talking about airflow, so this gives a definition, and we'll talk about that definition of how we can determine laminar flow versus turbulent flow. But you do need to know that turbulent flow increases resistance. Okay, just think about it. If the flow is very turbulent, up and down, has vortices, etc., within that flow, it creates a resistance because now you have airflow going in different directions perpendicular to the direction of flow, and it makes it more difficult. Also, we're going to talk about airflow resistances in series and in parallel. What is the difference between whether the resistance is series or parallel? We'll show you that mathematically because the upper airway, basically the resistance is in series, because if you think about the branching of the airway, it branches pretty much one to the other, even though there is a small amount of series, but it's more in a parallel. But as we go further down toward the terminal bronchioles, respiratory bronchioles, and the alveoli, all of our resistances are in parallel. In other words, they go across, because remember, the number of branches increases dramatically, so it's the number of branches, but those are in parallel. So we'll talk about how that affects it. And also we're going to talk about flow limitations relative to equal pressure points. In other words, the combination of our pleural pressure and our alveolar pressure, remember, alveolar pressure keeps the alveoli pushed out, it's a pressure pushing outward. Pleural pressure is something that actually pushes inward to some extent. So the external lung pressure. And this is mostly in reference to exhalation. Okay? Inhalation, as you know, we have a negative pleural pressure that opens the airways, but during exhalation, we do not. We have a less negative pleural pressure, and therefore, even during a forced exhalation, we get a positive pleural pressure. Okay, and we'll talk about that in more detail. So first, the Reynolds number. This is the equation of the Reynolds number. It's the radius of the airway, airflow velocity, air density, air viscosity. All of these factors fall into the Reynolds number. I'm not going to ask you to remember this equation. I do want you to know relatively what the Reynolds number means relative to airway resistance. Therefore, if the Reynolds number is less than 2,000, then laminar flow predominates and airflow for a given pressure will increase. Okay, so that means that we have laminar flow if Reynolds number is less than 2,000. This gives you an indication here. This would be laminar flow, turbulent flow based on diameter. So you can see that diameter is directly proportional to the Reynolds number. So that's one example. Also, if the Reynolds number is greater than 2,000, then turbulent flow predominates. So that's the point I want you to remember. And remember that some of the different things that may have an influence on that, primarily diameter is one of the bigger things that we talk about, as well as when we talk about airflow velocity. Now, once again, in our airway system, where is airflow velocity the highest? In the upper airway, the trachea, okay? The diameter is also the largest. So you see how that goes hand in hand. So velocity and diameter, as they increase, we increase the Reynolds number. So we have more turbulent flow in our upper airway than we do our lower airway. Thus, for a given airflow, a higher airway pressure is required to support turbulent versus laminar airflow. So what happens to airway resistance in laminar versus turbulent flow? Basically, airway resistance, as we mentioned, increases when we have turbulent flow. Okay, so just remember the relationship between the Reynolds number, turbulent flow, laminar flow. And it all makes sense when we refer to our airway, because we know that airway resistance is highest in the trachea relative down to the respiratory bronchioles and the alveoli. Now we talk about airway resistance. Airway resistance of the entire respiratory system takes into account the large airways, the medium airways, the small airways. Now, in general, these are the way it breaks down. The upper airways, or large airways, are primarily, resistance is in series. So resistance is equal to the summation of the various airway components. Resistance 1, resistance 2, plus resistance 3, etc. And that's the upper airway. Now, if we go to the lower airway, the resistances become more in parallel. As we discussed, because of the multiple branching, we have all of these alveoli and respiratory bronchioles in parallel. To calculate resistance in a parallel system, total resistance is equal to 1 over the resistance of that segment. So now if we add that up, so now you can see that resistance is a mere fraction if the system's in parallel rather than in series. So resistance to airflow decreases as lung volume increases. Now we talked about that during inhalation. So as we talk about inhalation, airflow decreases because we increase the diameter. Okay, so as we increase diameter, we decrease resistance. However, we do increase the Reynolds number, which increases resistance. But when you take diameter into account in both factors, resistance drops more due to diameter changes than it does the Reynolds number or turbulent flow. So those are kind of counterintuitive. So try to remember if we refer specifically to the Reynolds number and turbulent flow, or if we're dealing specifically by increasing the lung volume, that decreases airflow resistance. Okay, so that's a relative change. So don't confuse the two when we talk about them independently. All right? So I give you that heads up on that. That during inhalation, as we expand the lung, the larger volumes create a lower airway resistance. However, if you talk about in general, a larger diameter has higher turbulent flow, therefore higher resistance, if you're comparing them directly. So other factors that also increase airway resistance, as we mentioned, mucus, edema, contraction of bronchial smooth muscle, increase in air density, such as in scuba diving. So remember that all those other things also come into play in resistance. So just to go a little further when we're talking about airway resistance in small versus large airways. In small airways, we typically have laminar flow. That predominates, and resistances are primarily in parallel. Both result in low airway resistance. Okay, so they both add up to low airway resistance. Now, if you take a stethoscope, and I'm sure you've seen the doctor with a stethoscope many times, they'll put it on your back in different locations, and they say, take deep breaths, breathe out. Is what they're listening for are breath sounds. Okay, so if you have nice laminar flow, low resistance, you can't hear the breath sounds. They're silent. Now, in large airways where you have turbulent flow, which predominates, and resistances are both in series and in parallel, both result in higher airway resistance. Therefore, you get breath sounds. So you will actually hear a breath sound if there's a high airway resistance. So that's why a doctor listens, and you'll notice that they listen toward the top of your lung, toward the bottom of your lung. First of all, they're going to be able to see this difference between top and bottom of your lung. As well, now if they hear breath sounds in the bottom of your lung, that means you have an increased resistance where there shouldn't be an increased resistance. Therefore, indicating that you have some potential upper airway or other airway occlusions, whether you have mucus buildup, you have bronchoconstriction, anything that increases resistance is now prevalent, and the doctor can observe that. So just to give you an indication of what these breath sounds are and what a doctor is doing when they put a stethoscope on your back, listening to those breath sounds. This here just talks a little more about resistance as we talk about the airway generation. Remember, as the branching continues down, various generations of the branching, you can see how airway resistance comes down to very negligible because of what we have talked about, the small diameter, the fact that the resistances are in parallel rather than series. So up in the conducting air zone, which is this region here, you can see that we have this spike in resistance. It's very high in the upper airways, and as we get closer to the lower airways, to the respiratory zone, you see that resistance drops off rather quickly. So once again, increasing lung volumes, such as increasing the radius of the airways, and that will decrease resistance of the airways. Okay, so once again, as we increase our lung volume, we have a tendency to pull those airways open, which allow airflow to go through much easier. And also we increase the airway resistance through mucus, edema, contraction of smooth muscle cells, inspired gas density, and viscosity. Okay, so this kind of just portrays what we've already talked about. Now we're going to talk about flow limitations and equal pressure point. This is another thing that comes into play when we're referring to airway resistance. We've already talked about these curves. And the important now, this is an expiratory curve. Okay, so we're expiring down to residual volume. The important thing about these curves, and we talked about here, peak effort, peak expiratory flow rate, how important this number is, and this helps to determine how much resistance we're going to get, or what we're talking about is equal pressure, developing an equal pressure point, which we'll explain a little further. So here, the maximum inspiratory flow Inspiratory muscle effort increases with volume increase. Okay, which makes sense. So as we increase the volume of our lungs, our inspiratory effort has to increase. We have to put more work toward it as the volume increases because now we're going against the recoil. Okay, so we have to use more effort the greater the volume we put into our lungs. And of course, the recoil of the lung increases with volume increases, just as we talked. That's why our inspiratory effort increases. As well, airway resistance decreases with increase in lung volumes. So that's inspiration. And you see how the more we inspire, the greater the volume, we decrease resistance. Also, when we talk about expiration, now that's a little different. Expiratory effort, this peak expiratory flow rate, this is what creates various pressures. So now, remember, in a peak expiratory flow rate, what are we doing? We're using active expiration, okay, to achieve these peak expiratory flow rates, as we talked about, or even this FEV1. We talk about using maximal expiratory effort. Therefore, we use our abdominal muscles, our intercostal muscles, once again, to force that air out. Now, when we force the air out, we actually create a positive pleural pressure. And as I mentioned before, that positive pleural pressure squeezes on those airways, okay? And it's relative to the air alveolar pressure pushing outward, and it's a difference between those that determine whether those airways collapse or don't collapse. So here, when we look at an expiratory effort, this is a minimal expiratory effort, moderate expiratory effort, and a maximal expiratory effort. So the more that we put in for an expiratory effort, you can see that the flow rates can increase dramatically. So we can have a maximal expiratory effort or a peak expiratory flow rate that is very effort dependent depending on how much we push. However, down toward normal ventilation, normal breathing, slow breathing patterns, this is called effort independent region for flow limitation. So when we don't use our expiratory muscles very much, we don't enhance the flow limitation of the airflow due to constriction of those airways. Okay? So the more expiratory effort we put in, the more we squeeze those airways, the more we have flow limitations because we're adding resistance due to the squeezing of those airways. Okay? So we'll talk about that in a little more detail. But relative to disease, once again, asthma, emphysema. Now in this case, remember we talked that emphysema has multiple aspects of that disease. Emphysema is a very complicated disease. When we look at expiratory effort or expiratory flow rates, we're primarily referring to the resistance due to airway mucus accumulation. So in emphysema, those patients also have mucus accumulation in their airways, and that's what we're talking to when we're grouping this with asthma. We're talking about increased airway resistance. We're not talking about the loss of compliance in this case. We're referring to the occlusion of the airway. So you can see, even on this curve, we cannot get the expiratory flow rates that we would normally because we have such high resistance in the airway. So anything that has high resistance, you can see how we cannot achieve the same expiratory efforts and how that affects the total pressure volume loops or the expiratory flow loops. Now we're going to put this in context of what we talked about, looking at pressure points. Now, there's a lot of information on here. It's a little complex, and I'm just going to give you general scenarios that I want you to understand from this. Okay? This is primarily referred to forced exhalation. Once again, as we looked at those other volume loops, under normal passive exhalation, this does not come into play because we have a negative pleural pressure, and that negative pleural pressure helps keep the airways open. So as we do a forced exhalation, now we create a positive pleural pressure. So here we are at total lung capacity, no flow. So this is end inspiration. So we're at maximal volume, therefore the airways are maximally pulled open because we've got the most negative pleural pressure that we can achieve. In this case, we have a minus 30 centimeters of water pressure. So we open the airways. Now, as we do a forced exhalation, as we do in those tests when we're doing FEV1 or the peak expiratory flow rates, now we do a forced exhalation. So as we start our forced exhalation, we now create a pleural pressure of plus 60 centimeters of water. Because remember, we say exhale as fast as you can, okay? So you're going to maximally constrict those expiratory muscles and you're going to push it out. You create a positive 60 centimeters of water pressure. Now, initially, because you have such a high lung volume, as you start that forced exhalation, because remember, you're starting from a total lung capacity, the alveolar pressure is very high. So as we push on this alveoli or the lung, we create a very high pressure in the alveoli. The air moves out very quickly. So if you look at the pressures, now remember, the alveolar pressure that we create deep in the lung, in this case, is 90 centimeters of water, and it decreases to 0. Because remember, these pressures are all in reference to atmospheric pressure, and so we call that 0 just as a reference pressure. So the airway pressure decreases to 0 until we get it out of our airway. Okay, so now we go from 90 to 0. We create a positive pleural pressure. So our positive pleural is 60. So you can see as this numbers decrease from 90 to 0, where is 60? 60 falls kind of at the edge of the parenchyma. In other words, at the edge of the air system that has no cartilage in it, okay? It's the conductive air zone or the upper airway that has cartilage on it and it's kind of protected. Anything within the lung parenchyma here is respiratory airway, and that's not protected by cartilage. So as you look at this pressure point, and this is what we're going to call our equal pressure point, so the 60 here matches the 60 here. So we don't really collapse our airways initially. However, as we continue our forced exhalation, remember our lung volume is now decreased. With a decreased lung volume, we can't generate as high a pressure. So we still are maximally exhaling. Now we can only create a pressure of 80. This pressure, now as it comes from 80 to 0, look what happens to our equal pressure point. We are still contracting with the same muscle force contraction of a positive 60. So now this 60 falls inside the parenchyma or inside the respiratory zone, and there's no cartilage there to protect it. Therefore, the pleural pressure is greater than the airway pressure distal to this equal pressure point. So that's why we call this an equal pressure point. So anything distal to that equal pressure point, if it's still in the respiratory zone, is subject to collapse. So now as we continue to expire, when our volumes are lower, we collapse the airways. So we get premature collapsing of the airways, therefore we create a high resistance. And we're going to talk about how this occurs in disease. Because remember, when we talk about in disease, especially something like fibrosis, we start with small lung volumes. Therefore, exhalation, if you do a forced exhalation, all you're going to do is collapse those airways very quickly. Okay? So this is where the equal pressure point comes into play. Now, if you have healthy lungs, this will not happen. You will come to the edge, more of like this, and even here, you may start to collapse them, but if you have disease, this becomes a major complication because we cannot generate these higher alveolar pressures. These alveolar pressures are lower. Say if this was 60, so then we go from 60 to 0. So that moves closer to the alveoli, and we have more respiratory bronchioles susceptible to collapse. So as we look at this clearly now, we talk about the expiratory airflow resistance decreases, gas velocity increases, which decreases pressure. So that's what happens initially. And then the equal pressure point, we get this negative trans-airway pressure beyond the equal pressure point. Airway compression beyond this point. In other words, distally. All right? So in disease, as we mentioned, we have a greater resistive drop in pressure. In other words, that pressure drops more quickly because we have a lower pressure here. The equal pressure point is closer to the alveoli in non-cartilage airway. And increasing lung volume to offset airway resistance. That's one reason in many of these airway diseases we try to increase our lung volume, such as in emphysema, because we still have airway resistance, and at least in emphysema our compliance is well enough that we can increase our lung volumes. Therefore, we increase our residual volume, we increase our functional residual capacity, and those volumes always stay higher, and we ventilate at a higher lung volume. That's to help offset this difference in equal pressure point. So then the airway resistance continues to increase. You get crackles and rails on inspiration. Once again, that's what the doctor is listening for, these various sounds in disease, because now as we increase the velocity, we actually increase the resistance. You can actually get turbulent flow, and you can hear that with a stethoscope. Okay, so that's how all that pulls together. Once again, this just breaks it down as we just talked about, defining what the equal pressure point is. So we've already looked at that as we do a peak expiratory flow rate. And as this volume decreases, the equal pressure point moves toward the alveoli, causing collapse and stricture of the non-cartilage airways, and therefore we increase resistance. Okay, now we're going to talk about ventilation. First of all, any questions concerning airway resistance? I know we covered a lot of information there, but hopefully it all makes sense as it ties together. Question?
Why were you measuring water before? How many figures by?
Oh, in centimeters of water? You will find that typically when we talk about air pressure, we refer to in centimeters of water because typically it's the range at which it falls into. When we talk about partial pressures of gases, those are in millimeters of mercury. So the nomenclature is just a little different, but as we refer to air pressures, it'll always be in centimeters of water. Partial pressures or anything that deals with fluids are in millimeters of mercury, such as blood pressure, etc. Those are all millimeters of mercury. But partial pressures, they consider that the fluid phase of the air or the solid phase, therefore they use millimeters of mercury. So now we're going to talk about ventilation. Ventilation, as we referred to, minute ventilation is equal to tidal volume times frequency. So the nomenclature here, the dot above it means per minute or per unit time, volume per unit time. If there is no dot above it, it just means volume. So in that case, that would be expired volume, but with the dot, it's expired volume per unit time or expired per minute. So how much air do you breathe out each minute? So they define it as expired. They could also define it as inspired. It really doesn't matter. It's all about the same. But for some reason, they decided to use expired ventilation, or they call it minute ventilation. It's all the same thing, means the same thing. Once again, V sub T is tidal volume, frequency of breathing, how many times we breathe. So we've already discussed various aspects of ventilation. Now, we also talked about dead space. So when we refer to ventilation, dead space is a very critical aspect that we refer to. We mentioned that the upper airway in the conducting zone is considered anatomical dead space. So this is V sub AND, or anatomical dead space volume. We said that's typically 150 ml. Okay, so that's anatomical dead space. And if we look at tidal volume is equal to alveolar volume plus dead space volume. Okay, so that all makes sense. If we breathe in 500 ml in a tidal volume, dead space volume is 150 of that. Therefore, alveolar volume is 350. Now, if we do this per unit time, we do the same thing. We just multiply each of these times the frequency, which gives us minute ventilation. So our tidal volume turns into minute ventilation, or expiratory ventilation. And that's equal to alveolar ventilation per minute plus dead space ventilation per minute. Okay, so you can see how this equation evolves. And so make sure you understand the relationship between total minute ventilation is equal to alveolar ventilation plus dead space ventilation. As we talked about before, these equations are the same thing that we referred to when we talked about various ventilatory aspects, whether you have a high volume and a low frequency, or a low volume and a high frequency. Minute ventilation can still be the same. However, it has a huge effect on alveolar ventilation because the effect on dead space ventilation comes into play. Even though dead space is still 150, but as you multiply that times the frequency, you can see how we alter dead space ventilation within the total ventilation, therefore decreasing and altering alveolar ventilation. Make sure you understand that relationship. This here is just a practice question. Can you calculate alveolar ventilation from this information? All right. Now, one thing that we put in here, sorry, that thing's in the way, says weight, 200 pounds. Typically, dead space ventilation, or anatomical dead space, can be calculated as a per weight of the patient. So in this case, if they weigh 200 pounds, that means their dead space ventilation is going to be about 200 ml. Okay? So keep that in mind. So you may see that on there so you can calculate what the dead space volume is, anatomical dead space, based on the weight of the patient. And this is what some people will do, some physicians will do. They will estimate some of those numbers. Now, if we take, and we're going to look at other types of dead space. There's another thing called alveolar dead space. Alveolar dead space is considered alveolar dead space when there's no blood flow going by areas that are ventilated. Okay? So in this case, if we have a pulmonary embolus, where we have a blood clot in the lung, it blocks off a small part of your capillary bed. So now we have no blood flow going by this part of the lung. Any airflow that comes into here is not involved in gas exchange because there's no blood flow. If there's no blood flow, there's no gas exchange. Therefore, this is called alveolar dead space. Okay, so that can come into play, whether it's injury, disease, or anything along that line. So, once again, it's important when we're talking about alveolar dead space. Now, when we talk about alveolar ventilation, well, of course, this is now going to come into play because alveolar ventilation is defined as the ventilation or the airflow that participates in gas exchange. Okay, so now we have to subtract alveolar dead space. Now, if you add anatomical dead space to alveolar dead space. This is called physiologic dead space. So that means all of the dead space involved is physiologic dead space. Okay, so try to remember that alveolar dead space plus anatomical dead space is equal to physiologic dead space. So now we subtract that from total pulmonary dead space. So if you can work this out, once again, in calling this would be physiologic dead space, and now we can actually still calculate alveolar dead space. So we take this and we just make sure we add these together. All right? So make sure you understand the difference between alveolar dead space and anatomical dead space. Another thing that can occur in the lung, and we're going to talk about this a little more later, but there's also such a thing that is called a shunt. Now in this case, the airway is occluded. So if the airway is occluded due to, okay, we inhaled some large particles, so some of our small bronchioles get occluded by particles blocking that airway. We could have a mucus plug of some type, depending on what type of disease we might have or sickness we have. Either way, part of the airway becomes plugged. However, the blood flow continues by there. This blood that goes past this space and is not involved in gas exchange is called a shunt. Okay, so this is called an intrapulmonary shunt as opposed to an extrapulmonary shunt. We're going to define extrapulmonary shunt as a shunt or a blood flow that does not participate in gas exchange, but it's outside of the lung. Okay, so extrapulmonary means outside of the lung. Intrapulmonary means inside the lung. Either way, it's blood that goes from the right side of the heart to the left side of the heart and does not participate in gas exchange. Okay? One of the clinical things that when we refer to extrapulmonary shunts is what they call a PDA. It's just a patent ductus arteriosus. We talked about a fetus. When a fetus is developing, there's little to no blood flow through the lung. The blood flow bypasses the lung because a fetus does not use the lung for gas exchange. So the lung is developing without actually using it. So as what happens at birth, the circulation reroutes and pushes all of that blood flow through the lungs, so now that we do get blood flow. So sometimes is what happens in newborns is this shunt around the lungs does not close. And if it doesn't close, we have a right to left shunt, and that blood does not go through the lungs. That's called an extrapulmonary shunt. Okay? In that case, that's a right to left shunt. So there can be extrapulmonary shunts, there can be intrapulmonary shunts. But that comes into play as far as blood flow not being oxygenated. Therefore, we're not going to get as much oxygen to the rest of the body. That'll come into play shortly. And we can also talk about, when we talked about regulation, remember we talked about if, in the previous one, if there's no blood flow here, what's going to happen to the CO2 and the oxygen? Okay? The oxygen is, well, the CO2 is not going to increase. The CO2 is going to be very low because we're not adding CO2 to this. So if the CO2 is low, what happens? This airway constricts. Okay, low CO2, this airway will constrict, and it'll cause more airflow to go to the good part. All right, likewise, in this case, if we block the airflow here, therefore, we are getting no oxygen here. Oxygen is low. If oxygen is low in this area, this capillary, pulmonary capillary, will constrict and decrease this blood flow that goes through here, therefore decreasing the intrapulmonary shunt. So physiologically, that's how our body responds to these types of situations. So when this happens, we minimize the shunt. And also, we minimize the dead space. Okay, so that's how our body accommodates these various occurrences. But nonetheless, if you still have some airflow into alveoli when there is no blood flow, that is still called alveolar dead space. But our body does accommodate these to a great extent. Okay, so now we go back to dead space, wasted ventilation. We have physiologic dead space that we talked about. That's equal to anatomical dead space plus alveolar dead space. So under normal conditions, we talked about tidal volume being 500, anatomical dead space 150, alveolar dead space typically 0. Under disease, we can have the same thing, but now we can have also some alveolar dead space. And if you do the calculation, is what we're looking at here. We're looking at the amount of physiologic dead space relative to tidal volume. That's an important number. Under normal conditions, we have 30% wasted air. In other words, that's because of our anatomical dead space. However, that can double easily and increase to 60% if we have some degree of alveolar dead space. So it's important just to understand that that ratio is very important. And to calculate this ratio can be done with a couple different formulas here. This first formula here, that's dead space volume over tidal volume equals to 1 minus. This is the partial pressure of expired CO2 over partial pressure of alveolar CO2. Now, these can be measured in various ways. First of all, alveolar CO2 is actually in equilibration with arterial CO2. Therefore, you can do an arterial blood gas and determine what this alveolar CO2 is. Expired CO2, they can collect a sample of your expired gas, and that's a mixture of your alveolar gas plus your dead space gas. So it's that mixture that says how much dilution do we have or how much dead space relative to the alveolar. So by comparing the partial pressure of CO2 in these two samples will indicate to us what the ratio of dead space is to tidal volume. So that's an equation that can be used, or we can actually convert this equation, once again, VD over VT, using, once again, arterial CO2, because I said alveolar CO2 is the same as arterial CO2, and still looking at the expired CO2 divided by PaCO2. So you can use either one, and this is just the way that you can swap this equation around and calculate this VD/VT, the ratio of dead space. Okay, so make sure you know what these mean. Sometimes an equation like this, I might give that to you on an exam if I ask you a question concerning that. This is called the Bohr dead space equation, which actually uses physiologic dead space. Now there's also another method, Fowler's method, of calculating dead space, but that only looks pretty much at anatomical dead space, does not take into account alveolar dead space. So we are not going to be concerned with this equation. All right. So that's just looking at the ratio of dead space or physiologic dead space to tidal volume. Now we're going to talk more specifically about partial pressures of gases in the alveoli in the blood. Partial pressure of any gas, whether it's oxygen, CO2, nitrogen, helium, any of those, either in the alveoli or in the blood, is equal to the fraction of the concentration of the gas times the total barometric pressure. We've talked about this already. So the partial pressure of oxygen, whether it's in the air or in the blood, is equal to the fraction of that gas times barometric pressure. In this case, 21% oxygen in inspired oxygen times 760, which is barometric pressure. So this here is inspired oxygen. So that's what's coming from the atmosphere. that actually is equal to about 160 millimeters of mercury. Now remember, if we are talking about humidified gas, 100% humidity, we can subtract about 47 millimeters of mercury from the 760 and then use 21% of that if we're calculating that. So alveolar, so P sub large A O2, alveolar partial pressure of oxygen would be equal to 760 minus water vapor pressure, or 47, in brackets, times 0.21. Okay? So that's what your alveolar oxygen would be. Once again, so that falls true for all gases that we find, whether it's oxygen, nitrogen, any minor gases, argon, helium, anything that might be found in the gas that you're dealing with. And so the barometric pressure is equal to 760 at sea level. Now we're going to talk about how that can change. We've talked about it already. If you go to altitude, barometric pressure decreases. If it's high humidity, barometric pressure increases. I'm sure when you listen to the weather quite often, all they used to say is barometric pressure is rising, barometric pressure is going down. I know when I was younger, I used to hear that in a weather forecast, and I'd be like, well, what does that mean? You know, barometric pressure is increasing, barometric pressure is decreasing. I didn't have a clue what that meant. Because what it means is if barometric pressure is going up, that means humidity is increasing and it's going to rain. Okay? And if barometric pressure is stable or going down, that means it's not going to rain. So it just helps you to give you a better understanding of what barometric pressure means and if it's going up or down. Because if you live in a particular elevation, changes in barometric pressure can only be due to water vapor. Okay? So when they give you barometric pressure changes for a particular location, it's an indication of humidity increasing or decreasing in the atmosphere. So also partial pressure of gases in alveolar gas composition. This is what we just talked about. Barometric pressure minus water vapor pressure times the percent of oxygen. So you can see that the partial pressure of oxygen in the alveoli is less than atmospheric due to the water vapor. Because we know in the alveoli it's 100% humidified. So therefore, we know it's 100% humidified. We know it's 37 degrees. Therefore, we can just plug in 47 millimeters of mercury when we're referring to alveolar partial pressures. Okay, so here we go once again. This is for nitrogen, same calculations. So if you add these all up, they should equal 1. If you talk about the partial fractions, or if you talk about partial pressures, the partial pressures will all equal barometric pressure, or 760 at sea level. Another aspect I want to fill you in when we're talking about alterations in barometric pressure, one of the things you're going to hear about is how do we increase barometric pressure? Anybody have any idea? Other than going below sea level, say Mexico City or New Orleans, okay? I mean, they're below sea level, so therefore barometric pressure would be slightly higher. But what else can we do to increase or alter, increase barometric pressure? What happens when you go diving? You go under the water. Water pressure is much higher than air pressure, okay? So at sea level, you have 760 millimeters of mercury of gas above you. In other words, air doesn't weigh much, but it does weigh enough to create 760 millimeters of mercury. However, if you go underwater 33 feet, that's equivalent to an entire atmosphere. Okay? So 33 feet underwater is equivalent to 1 atmosphere. So if you are at sea level, and now you go 33 feet underwater while you're at sea level, what is the barometric pressure? 2 times 760. okay? 15, 20. So you just doubled barometric pressure. What's that do to the partial pressure of oxygen? You just doubled it, okay? Actually, a little more, because then if you talk about alveolar pressure, you only subtract water vapor once, okay? So you can see how diving can alter barometric pressure dramatically. So now if you go 66 feet underwater, now you're at 3 atmospheres of pressure, okay? So that's why when we talk about diving, and the barometric pressure or the partial pressure of gases can really change. One problem, what's the biggest problem with diving that you ever hear of? Divers getting the bends. Do you know what the bends are? The bends are when you go to a very high depth or a low depth. So you build the barometric pressure so high, typically nitrogen does not absorb into your tissues. Okay? It's inert. But remember, we breathe in 78% nitrogen. However, if you increase the partial pressure of nitrogen high enough, it will force it into your tissues. So now you're going to absorb nitrogen. So the bends are when you start surfacing. Now you decrease surface tension. Nitrogen is now going to decrease in partial pressure. So this nitrogen gas expands. When it expands, it's in your tissues. Okay? It's very painful. So what do you do with all this nitrogen that's in your tissues? They treat it with a hyperbaric chamber and high oxygen. Hyperbaric chamber, once again, they put you down to an equivalent pressure that you were at, so put you back to 3 atmospheres of pressure. The nitrogen gas becomes small again because of the high pressure, and then they slowly bring you to the surface, real slow, giving that nitrogen time to leak out of your system because they put you on 100% oxygen. You're no longer taking in nitrogen, so the nitrogen slowly diffuses out of your tissues as they bring you back to a normal atmospheric pressure. So that gives you a better understanding of what barometric pressure does to these gases. But of course, imagine what the oxygenation does under those conditions as well. Your oxygenation, or you increase the alveolar oxygen dramatically, and that becomes into equilibrium, as we're going to talk about, with your blood system. So the amount of oxygen going to your body is extremely high under high pressure. So keep that in mind as well. So now we're going to talk a little more about diffusion and transport of oxygen and CO2. Remember, oxygen comes in, CO2 comes out. So CO2 is the highest in the venous system because the venous system comes from the tissues. The tissues create the CO2 and they consume the oxygen. So the oxygen comes in. We have a metabolic rate of consuming about 50 ml of oxygen per liter. And then when we get down to the tissues, the full tissues, we have a metabolic consumption based on a cardiac output of 5 liters per minute of about 250 ml per minute. So metabolically, we consume 50 ml per liter, and adjusted for cardiac output, we consume about 250 ml per minute for a normal adult, and we produce about 200 ml per minute of CO2. So our CO2 comes back, and we're looking at per liter, because now we're looking at the volume of blood. There's 40 ml of CO2 per liter coming back to the lungs, and this is what has to diffuse back out and be removed. So we remove the CO2 that we produce in the tissues, and we bring in oxygen that we consume in the tissues. Okay, and once again, one thing that we look at is what we call a respiratory exchange ratio. That's nothing more than the exchange of CO2 and oxygen. So this exchange ratio, 40 over 50, or the 200 over 250, gives us that exchange ratio. There are certain diseases, once again, metabolic diseases, that alter this exchange ratio. And we'll mention a couple of those when we get to talking about gas exchange at the tissues. So once again, this breaks down very clearly all of the different partial pressures of atmospheric gas that we're inhaling. So this is P sub I, inhaled partial pressure of nitrogen, oxygen, CO2, relative to alveolar oxygen, CO2, nitrogen, and water vapor. Okay, so this is atmospheric, this is alveolar. Make sure you understand what the normal ranges are of these gases. Now, we mentioned before that the alveolar partial pressure of oxygen typically is about 100. It is not this closer to this 160 because of the consumption of oxygen. We consume so much oxygen on a regular basis, diffusion is very fast, that if you could directly measure the alveolar partial pressure of oxygen, it comes to an equilibration of about 100. So we have fresh oxygen coming in, we have oxygen being taken out through consumption, therefore the equilibrium is about 100. Same with the alveolar PCO2, it's about 40 millimeters of mercury in the alveoli, because we have a large amount of CO2 coming back where the partial pressure is about 46, but because of the air that's coming in has no CO2 in it, this dilution factor turns into about an equilibration of 40 millimeters of mercury. So make sure you know what these normal values are, because everything hinges on what normal is. So once again, we mentioned that the gases diffuse readily and they come to full equilibrium by the time the capillary bed gets to the end of the alveoli or the gas exchange area. They are in exact equilibrium with the alveolar gases. So once again, P small a, that's arterial. So partial pressure of arterial oxygen is 100. That'll be equal to alveolar. Same as CO2. Arterial partial pressure of CO2 is 40, same as alveolar. So once again, this is transported through the arterial circulation until it gets to the tissue. At the tissue level, it's consuming oxygen, therefore the partial pressure at the tissue is less than 40 millimeters of mercury, and we have a partial pressure of 100 coming here. And we talked about diffusion occurs anytime gas moves from high pressure to low pressure. So because the partial pressure is higher in the arterial circulation, low in the tissue, we have diffusion in that direction. Same with CO2. In the tissues, the CO2 is greater than 46, and it's only 40 coming from the arterial circulation, so CO2 diffuses into the blood. And that will come to equilibrium as it leaves the tissue capillary bed. And so once again, coming back through the venous circulation, now we have a venous partial pressure of oxygen of 40 because we consumed oxygen, and we have a partial pressure of CO2 at 46 because we produce CO2. Make sure you know what these normal values are. And once again, these are considered driving pressures, and that's very important because it's the same thing as we come across from the lung. Partial pressure of oxygen is 100. It's only 40 coming back to the venous system, therefore diffusion goes into the blood. Same with CO2. It's 46 to 40, it diffuses out. So it's important to maintain what we call pressure gradients because gases only diffuse if there's a pressure gradient and in the direction of the pressure gradient. So now we'll talk a little more about ventilation perfusion. Remember, ventilation and perfusion is where we match ventilation and perfusion. We talked about how the body accommodates ventilation perfusion differences. So as we alter ventilation, we alter perfusion to match that. So it's very important that our body does that to optimize the function of our lung. So we talk about perfusion. The pulmonary artery is what brings deoxygenated blood into the circulation. I'm not sure why they would show that in red here, but the pulmonary artery brings deoxygenated blood into the lung. that flows through the pulmonary capillaries in association with the gas exchange areas and becomes oxygenated and then will leave as pulmonary veins. We've talked about that before. So now when we talk about ventilation matching perfusion, we're talking about alveolar ventilation and perfusion ratios. So ventilation to perfusion matching. Once again, the pulmonary capillaries hold about 75 ml of blood at rest, and this can be recruited during exercise or additional need, and the capillaries can then hold up to 150 to 200 ml. So the capillaries will actually recruit. We talked before, if we don't have a lot of ventilation to an area, the capillaries will kind of constrict down a little bit. Well, that decreases the volume. But now if we're exercising, we increase our ventilation. Therefore, we dilate those capillaries. So now we increase the volume in which those capillaries can hold. So we can actually recruit up much of the capillary bed to more than double the volume that we're using for gas exchange. And also when we talk about perfusion, of course, reoxygenating the blood and dispensing of CO2, but also fluid balance in the lung. That's when we talked about the lymphatic system, maintaining that fluid balance, and also to distribute metabolic products to and from the lung. The lung acts as a very good clearing mechanism for a lot of circulating metabolites, as well as produces its own that it sends out to the rest of the body. So ventilation-perfusion relationship, we mentioned before, if you're standing or sitting in an upright position. I'm not going to ask you to remember all the numbers on here, but I do want you to remember whether the apical or the basal relative differences are. So when we talk about alveolar ventilation, the apical part of the lung gets about 0.24 compared to 0.82. So the basal part of the lung gets more of the ventilation. And perfusion, the same way. The basal part of the lung gets a lot more blood perfusion. Now this is under circumstances of rest. So at rest, as you're sitting there, the bottom part of your lung gets more of your tidal volume and gets more of your cardiac output than the top part of your lung proportionately. Okay, so as that goes, you can also look at the VQ ratio. Now that's because of the numbers here, we actually get more ventilation than perfusion, 3 times the ventilation to perfusion at the apical part. So the VQ ratio is much higher at the apical part rather than the basal part. And we're going to look at that again, but just try to keep that in mind, that even though the basal part of the lung gets more ventilation, more perfusion, the ratio of the two is much lower than that of the apical part. And if you look at the rest of these numbers, you can do this on your own, comparing oxygen, CO2. It's all relative to airflow and ventilation. Therefore, you can see that the CO2 is a little different, as well as the pH. I'm not going to be as concerned about these numbers here. We're not going to worry about that, but make sure that you understand just the relationship between ventilation and perfusion. If you have ventilation but no perfusion, you're going to be bringing oxygen in but not getting rid of CO2. So it really does depend on which is higher at the apical versus the basal. So you should be able to use these numbers and say, okay, that makes sense. Those are all pretty much straightforward. One thing that's not necessarily straightforward when we talk about the apical portion of the lung versus the basal portion of the lung is the difference when we talk about alveolar ventilation and perfusion. Now, under normal conditions, at rest, the pleural pressure is greatest, or more negative, so it's actually the least, at the apical portion of the lung. Now, that's due to gravity. Okay, so we're talking about the weight of the lung, that pushes out. So what happens is you got greater force down here because of the lung weight pushing out, so we decrease this pleural pressure and we increase the pleural pressure here. So the pleural pressure opens the airways more at the apical portion, but constricts the airways at the basal portion. But just because it's pulled open versus closed, that's at a normal resting position. So now when we talk about a tidal volume coming in, where does that tidal volume distribute? As we already mentioned, we get more of the ventilation at the bottom of the lung, at the basal portion of the lung. How does that happen if the airways are smaller relative to the top of the lung? That's because the compliance of the alveoli at the base of the lung are much higher. Okay, so as we look at the volume curve, so if we have higher compliance, remember, at larger volumes, the compliance is lower. So we have very poor compliance here. So you take something that's already held open, now we bring in 500 ml, it's going to go to the areas of least resistance or higher compliance. This has a higher compliance. In other words, this will expand easier because it's at a lower volume. Remember, we talked that as you increase the volume of the lung, you decrease compliance. So therefore, air does not flow into this, so we end up with a void here. In other words, this is already filled with air because it's pulled open at a basal level. So every time we bring in fresh gas, most of it goes down here because this will stretch. This will not stretch as much because it's already pre-stretched. All right? It's a little confusing, but try to make sure you understand this difference. Okay? So because of the pleural pressure differences and hydrostatic pressure, basically in the weight of the lung, the airways are in a basal position, more open, but they can allow to expand more because they're more collapsed at the basal part. So now when we look at this curve, we see that the bottom of the lung gets more ventilation. It gets more perfusion because the heart sits right here toward the bottom of the lung, and hydrostatic pressure keeps the blood down in the lower part of the lung just due to gravity. Therefore, of course, we get more blood flow here under normal conditions. So you can see that ventilation and perfusion are highest at the bottom, but when we look at the ratio, it switches by the time we get to the top. Ventilation becomes higher than perfusion at the top of the lung, and perfusion's higher than ventilation at the bottom of the lung. The ratio increases at the top, but that's only the ratio. Each ventilation and perfusion both are higher at the basal part. But remember, the ratio is in the opposite direction. Try to remember these basic points with this slide. Once again, this shows the same thing. It's kind of like if when you're at a TLC, a total lung capacity. Now, this would be recruitment. So as we increase the volume to above and beyond a normal tidal volume, we recruit everything up equally because now we create such a high negative pleural pressure. It pulls both the top and the bottom open. It compensates for the difference, as well as if we exercise. We increase our tidal volume, we increase our cardiac output, these all normalize. So now they become more equal as we recruit the entire lung. So those differences are basically when you're sitting at rest and not utilizing all of the lung. That's the distribution, but as we increase metabolic demand and exercise, they normalize. More so to the open position if you look at total lung capacity and you have a smaller ability for compliance, so compliance decreases, but now they become more equal. So factors that affect blood flow, perfusion through the lung. Once again, we talk about pulmonary vascular resistance. So this is going to affect blood flow through the lungs. So the resistance, in other words, we talked about the constriction of the capillary bed. The more they constrict, the more we increase resistance to blood flow. Gravity has effect on resistance or blood flow, as well alveolar pressure an arterial to venous pressure gradient. Blood flow goes from one side to the other based on a pressure gradient. So once again, that's also dependent upon cardiac output, exercise, etc. So blood flow is relative to change in pressure per pulmonary vascular resistance relative to the resistance of flow. Let's go ahead and do a couple questions. I know you guys really love to do these questions. Almost as much as I do. All right, now this time I'm going to give you only 2 minutes per question. Okay, so when this starts at 3 minutes, when it gets to 1 minute, we're stopping. So you have 2 minutes to answer. It should not take you 2 minutes. You should be able to answer within 1 minute. So, let's see. There's our first question. Which of the following will increase airway resistance? We talked excessively about airway resistance, breathing through a straw, singing in the rain, using an inhaler of antihistamine, or all of the above. Now, singing in the rain refers to talking, etc. What happens to airway resistance relative to that? Okay, you've got 1 more minute. Okay, you're down to less than 10 seconds. All right, time's up. Answer is breathing through a straw. Come on, we talked about breathing through a snorkel. A straw is even smaller diameter, higher resistance. That's a dead giveaway. Using an antihistamine will dilate the bronchioles and decrease resistance. So therefore, you know it's not all of the above. Even if singing in the rain, you couldn't tell the difference. Actually, singing, you sing at larger lung volumes. If you have larger lung volumes, what's that do to airway resistance? It actually pulls the airways open. Okay? So once again, we will now go to the next question. I know I'm going out of order on my list here, but that's okay, because they're more relevant. All right, here we go. Which of the following will increase airway resistance? So we've got decreased total cross-sectional area, decreased viscosity of air, decreased length of airway, Reynolds number less than 2,000. One minute left. Now, we just got done talking about this. It shouldn't take very long for you to answer this correctly. "30 seconds. Come on, let's get the last few folks in there. Okay. Answer is A. All right, now that's a pretty good percent. You know, I wish it was 100% because those were the easy questions. Now, when we get to the exam, you know, it's going to be a little different than that. All right, we'll go ahead and pick up from here next time. Thanks. How are you?